Good morning, everyone. Welcome back to another episode of Pathagonia. So today we're going to talk about vascular diseases. So the human organism, we're made up of a lot of blood vessels, as are other animals. So there's a lot of opportunity for vascular pathology. So the first category we'll talk about is vasculitis. This is inflammation of the blood vessel wall. It can be infectious or non-infectious. The clinical findings of vasculitis are diverse and depend on the organs involved. Generally, you'll have constitutional symptoms such as fever, myalgias, malaise, with or without localized tissue damage due to ischemia or bleeding, leading to single or multi-organ dysfunction with an elevated CRP and sed rate. These are classified mostly based on the size of the vessel involved and the organs involved. There are many systemic rheumatologic diseases such as rheumatoid arthritis, sarcoidosis, and lupus that can have associated vasculitis. And the main immunological mechanisms of non-infectious vasculitis are as listed below. So the three main categories of the mechanisms are immune complex associated vasculitis, anti-neutrophil cytoplasmic antibodies or ANCA, and anti-endothelial cell antibodies. In the immune complex associated vasculitis, you have antigen antibody complement complexes that deposit in the vessel wall and recruit inflammatory cells. These are seen with many systemic immunologic conditions such as lupus, drug hypersensitivity, and viral infections. In the ANCA category, you have antibodies that react with neutrophil cytoplasmic antigens, or ANCAs, activating neutrophils, which degranulate and damage the vessels. The two types of ANCA, MPO ANCA, formerly P ANCA, is seen with microscopic polyangiitis and Schergstrass, and PR3 ANCA, formerly C ANCA, which is seen in Wegener's. In the anti-endothelial cell antibodies, as the name suggests, antibodies attach to the endothelial cells. There are different categories. There's vasculitises that can affect variable vessels, such as Behçet's disease and Cogan syndrome, small vessel vasculitides, like immune complex and the ANCAs. Within the immune complex category of small vessel vasculitis, you have IgA vasculitis, or Hinoch-Schönlein purpura, cryoglobulin vasculitis, lupus, and Goodpasture disease. In the small vessel ANCA category, there is microscopic polyangiitis, Wegener's, and Schergstrass. The medium vessel category also has immune complex derived vasculitis, which could be polyarteritis nodosa, and anti-endothelial cell of Kawasaki disease. The large vessel category, you can have granulomatous vasculitis and giant cell arteritis or Takayasu arteritis. And you can also have vasculitides that affect the capillaries only, and those can be anti-endothelial cell, such as anti-glomerular basement membrane disease. And we'll go into more of these individually, but here's just kind of a framework for our further discussion. So the large vessel vasculitis, as suggests by the name, involves large vessels not inside of organs, with some medium-sized vessels, and histologically you're going to see lymphohistiocytic inflammation of the vessel wall with frequent granulomas and giant cells. You're also going to have fragmentation of the internal elastic lamina, which is best seen on the EVG stain. It can be patchy, so get lots of levels and an EVG in biopsies. And you'll also see nodular thickening of the intima with medial scarring. Within the large vessel vasculitis family, we have Takayasu arteritis, which predominantly impacts the aorta, particularly the arch and its major branches, and the onset is usually before age 50, with transmural fibrous thickening of the aorta with lumen narrowing particularly of branching vessels, with loss of pulses in the upper extremities. The other large vessel vasculitis is giant cell or temporal arteritis, which again usually impacts the aorta and or its major branches, with a predilection for the branches of the carotid and vertebral arteries, especially the temporal artery. Onset is usually after age 50, and it is the most common vasculitis in the elderly in the United States. It's often associated with polymyalgia rheumatica, with involvement of the ophthalmic artery, and it can cause permanent blindness. So it's considered a medical emergency requiring prompt diagnosis and treatment with corticosteroids. As these processes are histologically indistinguishable, they are often identified clinically, primarily by age. And here's what the histology may look like, some of that granulomatous type inflammation and destruction of the internal elastic lamina, as shown here. So here we have it intact, and here we have that internal elastic lamina fragmented, which would be demonstrated on an EVG IHC. So a medium vessel vasculitis involves the main visceral arteries and their branches, such as inflammatory aneurysms and stenoses are common. Within this category, we have polyarteritis nodosa, which is a transmural necrotizing arteritis of medium or small arteries without glomerulonephritis or vasculitis of arterioles, capillaries, or venules, with mixed inflammation, fibronoid necrosis, and thrombosis. Polyarteritis nodosa frequently involves the renal artery in the GI tract, and it's often patchy or segmental. It's immune complex mediated, and about 30% have chronic hepatitis B. Next up, we've got Kawasaki disease, also within the medium vessel vasculitis family. And Kawasaki disease is also known as mucocutaneous lymph node syndrome. It's an arteritis that impacts medium and small arteries, usually in individuals under 4 years of age, presenting with oral, conjunctival, and palmoplantar erythema, also known as strawberry tongue, with a desquamative rash and cervical lymphadenopathy. It is often post-infectious and predominantly involves the coronary arteries, leading to aneurysms and myocardial infarction, which would be quite rare in individuals otherwise under the age of 4. You wouldn't expect to see any kind of heart disease like that. In Kawasaki disease, there are autoantibodies to endothelial smooth muscle cells, and you treat this with IVIG and aspirin. And here's an example of what you may see under the microscope for a medium vessel vasculitis. You can appreciate tons of inflammation, fibronoid necrosis, and maybe even some thrombosis. So moving right along, the small vessel vasculitis. It is often neutrophil predominant and leukocytoclastic, leading to fibronoid necrosis, thrombosis, and red blood cell extravasation. The first category is ANCA-mediated, so microscopic polyangiitis, or MPA, is a necrotizing vasculitis of small and medium vessels with mixed inflammation with fibronoid necrosis. And it very commonly involves the kidney and lung. MPO ANCA is usually positive. Next up, granulomatous with polyangiitis, Wegener's, is a necrotizing granulomatous inflammation that commonly impacts the lung, nasal cavity, and kidney. In the lung and head, you see granulomas with geographic central necrosis and associated vasculitis, which forms ulcers and nodules. In the kidney, you can see crescentic glomerulonephritis, or PR3 ANCA positivity is also common in Wegener's. And that is an image of what you may see in Wegener's up top. Next up, we've got eosinophilic granulomatous with polyangiitis, or Schergstrauss. This is an eosinophil-rich and necrotizing granulomatous inflammation. As shown here in the image, you can see all these eosinophils, And it often impacts the lungs and is associated with asthma and eosinophilia, and it's going to be MPO ANCA positive typically. The next category is immune complex mediated. So this is, the first one is IgA vasculitis, or high Knox-John-line purpura, which is a vasculitis with IgA1 dominant immune deposition. Often involving the skin, you'll have palpable purpura, GI tract or abdominal pain, kidney and joints, leading to arthritis, and it's the most common systemic vasculitis in kids. It's usually self-limited and post-infectious, often after an upper respiratory infection. In cryoglobulonemic vasculitis, you can have serum cryoglobulins, which are antibodies that precipitate out of solution at less than 37 degrees Celsius, leading to vessel deposits and vasculitis, and it often involves the skin, kidney, and peripheral nerves. There's a high association with hepatitis C and monoclonal gammopathy. Next up, we have hypocomplementemic urticarial vasculitis, or anti-C1q. It's associated with the anti-C1q antibodies, leading to immune complex deposition, activation of the complement cascade, mast cell degranulation and neutrophil activation, and urticaria, and small vessel vasculitis. Lastly, on this page, we have anti-endothelial cell antibody mediated, or anti-glomerular basement membrane disease, or Goodpasture syndrome, which impacts the capillaries in the kidney, lung, or both. And in the lung, you'll see hemorrhage, and then in the kidney, you'll see crescentic glomerulonephritis, which is what we're seeing here. An example of Goodpasture syndrome involving the kidney, and that would be a good picture to be aware of. You can see it certainly doesn't look like healthy kidney, and something to be mindful of. So for the variable vessel vasculitis category, like as mentioned before, you can have Behçet's disease or Cogan syndrome. Cogan syndrome is a systemic vasculitis with predominantly ocular and inner ear findings that may also involve the aorta and the heart, while Behçet's disease is a vasculitis involving arteries or veins of any size with recurrent oral and/or genital aphthous ulcers, accompanied by cutaneous, ocular, articular, GI, and/or CNS lesions, and you can get thrombosis or aneurysms. It's most common along the ancient Silk Road, so the Middle East to Asia. The infectious vasculitis category is most often due to direct extension of infected tissue. It can cause aneurysms, such as mycotic aneurysms. And some examples where vasculitis is an important component of disease include syphilis, where you can have luminal obstruction and perivascular infiltrate of lymphocytes and plasma cells. I always associate syphilis with plasma cells. They seem to pop up in the skin and in the GI tract and elsewhere when syphilis is present. For fungi, such as Aspergillus and Mucor, this can cause disseminated infection with angioinvasion. Usually occurring in immunocompromised patients, it causes obstruction leading to tissue necrosis. Some other examples of infectious vasculitides are Rocky Mountain spotted fever, Q fever, typhus, meningococcus, and Lyme disease, all having vascular pathology within their realm of destruction. Next up, we have IgG4 related aortitis or periaortitis. So you'll have characteristic findings in the adventitia, such as dense lymphoplasmacytic infiltrate, storiform type fibrosis, obliterative phlebitis, and you must see more than 50 IgG4 positive plasma cells in a single high-powered field to call this. And IgG4 related aortitis often occurs in older men. So a few coagulopathic disorders. You want to look for bland, non-inflamed thrombi in vessels. So we'll go through a handful of them. So the first is DIC, or disseminated intravascular coagulation. This is a consumptive coagulopathy where systemic activation of the coagulation cascade leads to thrombosis of small vessels throughout the body and also bleeding. It can occur in many settings, such as sepsis, trauma, and you can see fibrin thrombi in small vessels. Next up, we have thrombotic thrombocytopenic purpura, or TTP. This is a thrombotic microangiopathy with widespread platelet thrombi in small vessels. It can cause hemolytic anemia, purpura, thrombocytopenia, and renal dysfunction. It results from a deficiency of Atom TS13, and you're going to see platelet-rich occlusive thrombi. You can also have hemolytic uremic syndrome, or HUS, which is similar to TTP, but the thrombi are mostly limited to the kidneys, and it usually occurs in kids after eating E. coli 0157H7, which makes the Shiga-like toxin, which is toxic to endothelial cells and can lead to bloody diarrhea. Lastly, on this page, we have heparin-induced thrombocytopenia, or HIT, which is when antibodies recognize heparin plus the platelet factor IV complexes, which activates platelets, leading to thrombocytopenia and thrombus formation. Usually the thrombi are in large vessels and can cause DVT or PE. And here are some images of those bland thrombi in vessels that you're looking for in coagulopathic disorders. So here we can see we're looking at a vessel lined by endothelial cells, and you've got a little thrombus or a thrombi within that vessel. The next category is vascular deposition disorders. First of which is amyloidosis. So in amyloidosis, there is deposition of abnormally folded protein, which is rich in beta sheets in the vessels and the tissues, which obstructs flow and makes it rigid, which impairs vasoreactivity, leading to ischemic injury and also making the vessel brittle, which can lead to hemorrhage. You can have extracellular eosinophilic amorphous material seen on H&E as shown here. Or if you use the Congo red stain, you'll have apple green birefringence. The Congo red stain, also known as the pathology bad boy stain. And you can also have, with the trichrome, it can lead to a grayish type stain, which will indicate that amorphous deposition of the amyloid, or if there's fibrosis, you'll have a bright blue staining. And you can subtype amyloid based on the table below to determine etiology using IF, mass spectrometry, immunoblotting, IHC, and more. And I will let you review this table on your own to break it down into systemic amyloidoses, localized, hereditary, and systemic senile amyloidoses. And you can also see the precursor proteins for each category. So I will let you review that on your own, and that is from Robbins. So some other deposition disorders are light chain deposition disease, or immunoglobulin light chains, which deposit in tissue in non-amyloid form. This is seen with immunoglobulin producing neoplasms and looks similar to amyloid on H&E, but not Congo red positive with apple green birefringence. So this is often due to kappa light chains. In calciphylaxis, you'll have progressive skin necrosis due to calcification of small and medium-sized vessels, and it's usually a result of hyperparathyroidism seen with chronic renal failure, and also you'll see thrombi with soft tissue calcifications, paniculitis, necrosis, and ulceration. Another deposition disorder is oxalosis, which is deposition of calcium oxalate crystals in vessels and tissues, which occludes the lumen, leading to ischemia, which can be primary due to enzyme deficiency, or secondary due to ingestion of oxalates or ethylene glycol, such as antifreeze. Or you can also see birefringent crystals associated with foreign body giant cell reaction. So our next category are common aging-associated disorders. So first up, we have atherosclerosis. So this is such an important topic, this whole category? So this is atherosclerosis is the development of atheromatous plaques in arteries. It's often most noteworthy in the coronary arteries, which can lead to myocardial infarction or stroke if it occurs in the cerebral arteries. You can also have peripheral vascular disease, not just the central vessels can be involved. And the pathophysiology is you have endothelial injury or inflammation, which leads to accumulation of lipoproteins, which are ingested by macrophages, leading to foamy macrophages in the intima, or a xanthoma with a fibrous cap, calcifications, and smooth muscle proliferation, which gradually grows and narrows the lumen. This can rupture, trigger thrombosis of the rest of the lumen, lead to ischemia, and of course lead to infarction. So we can see here this outline of a vessel wall, and then we have this big atheromatous plaque which narrows the lumen and is not going to be as efficient to allow blood to travel. Imagine if this was one of your coronary arteries that looked like this. Obviously that could lead to ischemia and potentially myocardial infarction or death of some of that cardiac tissue. So risk factors for atherosclerosis: obesity, diabetes, smoking, hypercholesterolemia, being male, and hypertension and inflammation. So some hypertensive type changes that you can see. These are most commonly associated changes with benign hypertension, but also can generally be seen with aging. First up, you have intimal fibroplasia of the small arteries, or arteriosclerosis, as shown in the image on the right, where you have deposition of collagenous extracellular matrix and vascular smooth muscle cell growth between the endothelium and the IEL, leading to thickening of the intima and narrowing of the vessel lumen. Secondly, you can also have hyalinization of the arterioles, or hyalinosis, which again is amorphous eosinophilic material, PASD positive, Congo red negative, made up of plasma proteins with the matrix, and it's also associated with diabetes. In malignant hypertension, you can see hyperplastic arteriosclerosis, leading to small arteries that have thickened and have an onion skin-like intima or concentric layering pattern with fibrinoid necrosis and thrombosis. So underlying pathophysiology, obviously hypertension, increased blood pressure, higher pressure flowing through these vessels over time causes various changes that you don't want to be there, thickening of the vessel walls, and then of course if you have issues in your diet or you have elevated cholesterol, not only can you have thickened vessels from hypertension, but you can also have atheromatous plaques, so not a good situation. So we want to be fit and healthy and keep our blood flowing smoothly and evenly, and so we can live long and happy lives and study pathology. So the next category are intimal proliferative disorders. In these, you have expansion of the intima by smooth muscle cells and myofibroblasts, and this is a common consequence of vascular injury and vascular activation, such as a common endpoint of many diseases. So the hypothenar hammer syndrome is a direct mechanical injury of superficial vessels, classically of the ulnar artery on the hypothenar surface of the hand from overuse of a hammer, which leads to lumina occlusion and thrombosis with scarring and ingrowth of capillaries into the media, which can present with signs of vascular insufficiency, such as cold, pale, or cyanotic hands. And that's interesting that that's just caused mechanistically by overuse, specifically overuse of a hammer. So that's interesting that pathophysiology can occur just from a pretty benign act, just working. Next up, we have moyamoya disease, which is most common in Japan. It is idiopathic with multiple spontaneous occlusions of cerebral arteries. can cause secondary development of adjacent net-like systems of collaterals that look like a puff of smoke on angiography, which can rupture, leading to stroke. So the last category on this page are arterial dissections. So I have seen a few of these this month on my rotation at the medical examiner. So good to be aware of. Definitely something good to study and be mindful of. So in arterial dissections, you have disruption of the vessel lumen. So blood can enter a false lumen and dissect between layers or rupture, which is frequently caused by trauma, but it can be sporadic. So some common sites of arterial dissections are cervical, such as the carotid or vertebral arteries, often in younger adults, or the coronary arteries. The aorta, often in older males with a history of hypertension, and aortic dissection can also be associated with Marfan syndrome and the bicuspid aortic valve. There are different types, such as Stanford type A, involving the ascending aorta, which is more common, and Stanford type B, only the descending aorta. And there's other various aortic dissection classification systems if you want to review those on your own. So with sporadic cases, microscopically, you often see cystic medial degeneration with marked loss of elastic lamella, which is best seen with the elastic stain. And you'll have deposition of proteoglycans, which is best seen with the colloidal iron stain. So that elastic stain is going to show that marked loss of the elastic lamella, as shown here. So you have normal elastic layers and loss of the elastic layers, and this is using the EVG stain. In this image on the right, we have proteoglycan accumulation as demonstrated by colloidal iron. So we'll end with just a few miscellaneous disorders, first of which is fibromuscular dysplasia. Fibromuscular dysplasia is replacement of the normal component, usually smooth muscle, by loose fibrous tissue, which causes narrowing and weakening, leading to aneurysm formation, like beads on a string. This often involves the large to medium-sized blood vessels, especially the renal arteries, causing hypertension due to the renin-angiotensin-aldosterone system. So if you have that narrowing of the renal arteries, it's going to activate that renin-angiotensin-aldosterone system, which can lead to hypertension. And fibromuscular dysplasia is more common or often occurs in middle-aged women. Next up, we have thromboangiitis obliterans, or Buerger disease. So this almost exclusively occurs in middle-aged males who are heavy smokers. It's thought to be a pathologic response to smoking with acute thrombosis of peripheral vessels, which invokes an inflammatory response, so it's not a true vasculitis as the internal elastic lamina is still intact. Next up, we've got angiodysplasia of the gastrointestinal tract. So this is an arteriovenous malformation, often in the cecum of elderly patients, which can cause a GI bleed, and it's thought to be degenerative with dilated capillaries and veins in the submucosa and mucosa, and it's sometimes called vascular ectasia. Next up, we've got cerebral aneurysms, also known as a Berry aneurysm. So this is a saccular aneurysm from localized structural degeneration, which is loss of the internal elastic lamina and muscle layers, which typically occurs in the circle of Willis, and it is relatively common. So in about 5% of the population, it's associated with connective tissue disorders, polycystic kidney disease, and hypertension. And a Berry aneurysm rupture often leads to subarachnoid hemorrhage. And here you see an example of a Berry aneurysm occurring in the circle of Willis. The next category are aortic aneurysms. So AAA, abdominal aortic aneurysm, is associated with atherosclerosis. It's most common in older male smokers. So you want to screen that population with an ultrasound. And it's often just above the bifurcation with a plaque and thinned media and bland laminated mural thrombus. If rupture, it's often a massive fatal hemorrhage, and the risk is proportional to the size of the aneurysm. So next up, we have thoracic aortic aneurysm, again, usually associated with hypertension and sometimes Marfan syndrome. As it dilates, it encroaches on nearby structures, which makes it harder to swallow and breathe, and leads to aortic valve insufficiency. It can also rupture and lead to massive hemorrhage. All right, next up we've got idiopathic myointimal hyperplasia of the mesenteric veins. So this is rare, usually occurring in young to middle-aged men with GI pain and or bleeding, most commonly in the left colon, and it can clinically look like inflammatory bowel disease. So on resection, you'll have mural mesenteric veins that have concentric proliferation of smooth muscle cells in the intima and the media, as shown here on the right. And on biopsy, you have these arterialized capillaries with subendothelial fibrin deposits, fibrin thrombi, and perivascular hyalinization with reactive epithelium or mucin depletion with or without usual ischemic changes. So here's some images of what you might see on biopsy or under the microscope. You can see that thickening of the vessel walls and the arterialization of these capillaries. So the last entity is enterocolic phlebitis, which is a localized lymphocytic perivenular circumferential cuff of inflammation that leads to venous engorgement, hemorrhage, and necrosis. This is usually right-sided in the middle-aged or elderly, and it can be necrotizing and or granulomatous. So that's it. Thank you for tuning in to another episode. We appreciate your support, and I hope these videos are helping you. Have a good day.